Bismillahirrahmanirrahim. Mr. Chairman, dear colleagues, it's my pleasure and honor to participate in such an elegant meeting. My talk today is about the RV function in heart failure. It needs more. I think it needs more understanding of the pathophysiology, the RV behavior throughout the heart failure process. Right ventricular dysfunction is a known critical determinant of functional capacity and prognosis in heart failure patients, regardless of the degree of LV dysfunction. The current guidelines classify heart failure based on the LV ejection fraction without consideration of RV dysfunction. This could be partially due to the fact that the definition of RV dysfunction remains unclear and the choice of optimal parameters for assessing RV function is usually inconsistent. The pathophysiology. The normal function of the right ventricle is the result of interplay between venous return, which is the preload, pulmonary artery pressure, which is the afterload, right ventricular myocardial contractility, interventricular dependence, and pericardial compliance. And actually, any change of any of these parameters will affect the other in both direct and indirect ways. As we can appreciate, the pressure loop curve changes if the RV having impaired function only, or differently when there is increase in afterload, and more different if there is increased afterload together with the impaired systolic function. The afterload change theory relies on the pulmonary artery pressure. Actually, the chronic right ventricular failure due to LV failure most commonly result from gradual backward transmission of elevated LV failing pressure causing the post-capillary pulmonary artery pressure. So, traditionally, the presence of pulmonary artery pressure has been associated with considered a cause for association of RV dysfunction in heart failure patients. This hypothesis has a sound of a pathophysiological background. However, in a substantial proportion of heart failure reduced ejection fraction patients, RV function may be reduced despite normal pulmonary artery pressure. This might be related to changes in RV contractility patterns, as approximately 20 to 40% of RV systolic performance can be attributed to LV contraction. And it was found that RV adapts its pattern of contractility and function according to the degree of LV systolic function. Normally, RV is having three main mechanisms to contribute to the total RV pump function. First one is the longitudinal shortening of the axis due to traction of the tricuspid valve toward the apex, and this is called the longitudinal ejection fraction, and it's labeled in red. The radial shortening, which is inward motion of the RV free wall, and finally the anteroposterior shortening, which is the contraction of interventricular septum and it's bulging into the RV. In the normal RV, the longitudinal component has long been considered the dominant contributor to more than 50% of RV pump failure. Let's see how RV will behave when LV starts to deteriorate. This is, as we said, the color codes. This is the longitudinal, radial, and anteroposterior. When the LV mildly started to be impaired, the radial force is more increased to compensate the reduction in both the anteroposterior and the longitudinal, and more reduction of the LV ejection fraction cause more increase in the radial force of the RV to compensate the reduction of both mechanisms, and finally the 3 is reduced when the LV starts to deteriorate less than 20%. هل ده معناه ان ال RV dysfunction is usually presented in reduced ejection fraction only؟ لا. The prevalence of RV in reduced ejection fraction is more pronounced with a significant proportion, 47%. However, the preserved ejection fraction can also have RV dysfunction, but to a lesser extent. However, information on the determinants of RV dysfunction in preserved ejection fraction is poorer. And in meta-analysis of studies of heart failure with HFpEF, it was presented in 28%. If the RV dysfunction is assessed using TAPSE, 21% if it is assessed by tissue Doppler, and finally 18% if it's assessed using the fractional area change. So it depends on the method of assessment. The diagnosis of RV dysfunction in heart failure. أكيد clinically we can see the clinical manifestation together with the echo. We will see it in details in the few next slides. The biomarkers elevation like the BNP, cardiac troponin, lactate, and D-dimers I will not be focused on the hemodynamic parameters in this lecture, and the MRI to assess the RV volumes and the pattern of fibrosis, which will make us understand more the pathophysiology of the disease. Echocardiography. The main core of assessment of RV in heart failure patients is not only to assess the RV function and pulmonary artery pressure. We should assess also the pulmonary artery RV uncoupling. What is the pulmonary artery RV uncoupling? It refers to the relationship between the RV contractility and the afterload. And pulmonary artery uncoupling with the RV occurs when the RV contractility cannot increase to match the RV afterload, resulting in RV dysfunction and decrease in stroke volume and right side heart failure. As we can see, if any pulmonary artery pressure elevation mildly, this will lead to reduction of the stroke volume عكس ال LV where it behaves differently. So what is the importance of assessment of RV pulmonary artery coupling in echocardiographic examination of patients of heart failure? It is considered a terminal state of many cardiovascular disease and play an important role in the pathophysiology and progression of the heart failure. Therefore, early and accurate evaluation of RV-PA coupling is of great significance for patients' condition assessment, clinical decision, and risk stratification and prognosis judgment. We will go rapidly through the conventional measurements like the RV dimensions. Usually we measure the dimensions in the apical four-chamber view, but we see many studies of getting the apical four-chamber view in that way or that way or that way, and there are discrepancies in the dimensions, and the correct one is the right ventricular focused view. This is the one that you should be using during the measurements. And of course, RV size in this method may be underestimated due to the crescent RV shape, and the dimensions measured in the RV in the apical four-chamber view is neglecting the RVOT part completely. D-shaped septum, and we measure the eccentricity index. LV eccentricity index is the ratio between the D2 to the D1. If it's more than 1.1 in systole and or diastole, it means that the RV is compressing the LV. And the RV wall thickness in the subcostal view at the tips of the opening of the tricuspid valve is less than 5 millimeter. There is no criteria for defining abnormally thin RV wall in the late stage of the diseases of heart failure. Pulmonary artery pressure estimation through, of course, the RV tricuspid gradient and the IVC measurements, but sometimes the RA is having a high pressure, and this will lead to unnoticed tricuspid regurgitation jet, and this will make our job to estimate pulmonary artery pressure is more difficult. And finally, the RV systolic function, both longitudinal and global. Longitudinal using the TAPSE, a tissue Doppler, and the global longitudinal strain. And the global function using the MPI, fractional area change, and for the ejection fraction. Rapidly, the TAPSE by M mode at the lateral annulus, abnormally it's less than 17. Of course, it has limitation if the patient is having any tricuspid repair or something is not applicable. A tissue Doppler, if it's less than 9.5 centimeter per second, it's considered abnormal, and also it's angle dependent and heart rate dependent. Global longitudinal strain, which is important for both the diagnosis and prognosis, and we can measure the free wall strain and the global longitudinal strain, and it was found it has a very powerful prognostic value to across the range of heart failure, and this study was published last year highlighting the importance of assessing the strain as a routine in heart failure patients for RV. The RV global function using the MPI as an index of global performance. Of course, we all know about it. I will go rapidly. And if we use the tricuspid Doppler, if it's more than 0.4, it indicates RV dysfunction. Fractional area change, if it's less than 35%, we trace the endocardial border in both systole and diastole. And by this equation, we can get the ejection fraction of the RV, and its advantages: it established prognostic value, reflect both longitudinal and radial components, and correlates well with the CMR. The limitation: it neglects also the outflow tract of the RV to overall systolic function. Finally, our lovely 3D echo assessment is more accurate and more important, and if it's less than 45%, it is considered abnormal. As we can see, we can trace the RV in each level and in many directions, and here we can see the mesh of in systole and in diastole, and geometrical assumption is not there, and it includes the RVOT contribution to overall function, and this will overcome the previous methods. But the limitation is that the image quality, the heart rate, and it should be needs a specific 3D echocardiographic equipment training. So collectively, regarding to sensitivity and specificity, 3D echo compared with the TAPSI and with the fractional area change, 3D echo always wins. The prognosis, which is the last thing, it's most important, the prognosis when the RV systolic dysfunction is there in heart failure, it's associated with increased morbidity and mortality, irrespective to the degree of LV dysfunction. As the reported 2-year mortality in a cohort of patients with HFpEF, it reached 45% if there is RV dysfunction, and 7% in those without. This is a huge discrepancy in the mortality outcome. How to measure the prognosis? As we said, with the pulmonary artery coupling measurements. We assess the systolic function and divided by the pulmonary artery pressure. Let's focus more on the methods. TAPSI over the pulmonary artery systolic pressure, if it's less than 36, it indicates poor prognosis. RV free wall longitudinal strain in relation with the pulmonary artery systolic pressure, if it's less than 0.6, it also indicates poor prognosis. And if we use the global longitudinal strain rather than the free wall, in relation also to pulmonary artery systolic pressure, if it's less than 36, it includes poor prognosis. And finally, the TAPSI over the pulmonary artery systolic pressure ratio was found in many studies that as a powerful indicator for prognosis in heart failure. As we can see in the red, this resembles the LV ejection fraction less than 40 and the TAPSI over pulmonary artery pressure less than 36. This when the ejection fraction is more than 40, and so the mortality and outcome is worse when it comes to this method. سريعا, MRI to assess volumes, pattern of fibrosis, etiology of the disease, and it differentiates the pulmonary hypertension, the idiopathic without LV affection, like here it's compressing the LV, the pattern of fibrosis, or it's part of the dilated cardiomyopathy disease, like here, or finally, if it's the primarily affected, like patients with arrhythmogenic right ventricular dysplasia. Last slide, the LVAD. RV evaluation is the key role in the selection of candidates of LV implantation, even before and after the implantation. And this protocol, it's called the SINA protocol. What is the abbreviation of SINA? Systematic left ventricular assist device, implant eligibility with non-invasive assessment. Those are the echocardiographic assessment methods for things to be assessed before the patient go to the OR to have LVAD. If the measurements is like this, this indicates a poorer RV assessment, and it was published in 2017. RV sphericity index, we divide the longitudinal over the mid dimension. If it's more than 0.5, RV fraction area change less than 35, free wall longitudinal strain if it's more than 11, minus 11, and 3D ejection fraction if it's less than 35. This indicates RV dysfunction after implantation of LVAD. And finally, my conclusion, right ventricular dysfunction is present in heart failure preserved ejection fraction and is even more pronounced in heart failure reduced ejection fraction for any given degree of pulmonary hypertension, as it is independently predicted by LV dysfunction, not the pulmonary artery pressure. Right ventricular arterial coupling is prognostically important and should be assessed in every patient with heart failure, regardless to the left ventricular ejection fraction. And finally, the separate quantification of RV mechanical components can hold additional prognostic value, particularly in patients with normal ejection fraction. And thank you. شكرا ربنا يخليك. شكرا جزيلا.
Assalamu alaikum. أهلا بحضراتكم. So I made my life easy because I will speak about the RV or the 3D echo again, so she covered some part of the RV at the end. Good. So it's about 3D echo and heart failure, indications and drawbacks. All of us agree, as well as the guidelines, that echo is the initial investigation tool or the initial screening tool for any patient who comes with symptoms of heart failure, right? It is not only at the initial screening stage, even if you have a patient that had echo and he has established heart failure, once you start medications for this patient, you anticipate that ejection fraction will improve. What you will judge with, again, echo for serial follow-up. Or if you are giving the patient medication that can actually impair the ejection fraction like chemotherapy, again, echo is indicated for serial follow-up. Or if the patient had any change in the clinical status, again, transthoracic echo at least will be the first screening tool to check if anything went wrong or if the symptoms is not related to the heart. That's because transthoracic echo basically give us idea about many things: the LV size and function, the geometry, wall motion abnormalities, the RV parameters like Soha illustrated nicely, the atrial size, the valvular affection, because symptoms of heart failure can be because of ischemia, can be because of valvular dysfunction. So the thing that will tell you which is the transthoracic echocardiography. That's why it's very valuable screening tool for those patients. The recent guidelines, whether the American or European, all of them agreed that transthoracic echo should be in the initial screening and the serial follow-up, as we said. Although ejection fraction is not the only thing assessing the systolic function, but still it is the cornerstone for dividing patients, classifying patients for HFrEF, HFmrEF, or HFpEF. It is still the ejection fraction, although we know that there is a strain, speckle tracking, but still ejection fraction is the benchmark for dividing those patients. The problem of 2D assessment of the ejection fraction volumes are actually two main things. Number one, the foreshortening. Many times we do the apical four-chamber view and we are really foreshortened, but we convince ourselves that's a nice apical four-chamber view, and we know that it's foreshortened. And we started to know that more and more after we started 3D echo, we realized that actually we are many times foreshortened. Second thing, the geometrical assumptions, as Soha illustrated. Most of the equations that we use in calculation of the ejection fraction are based on the assumption that the LV is a bit bullet shaped, right? If it is not bullet shaped, this equation is not valid. What even Simpson method, where at the end of the day we are measuring apical fourth chamber and apical two chamber. What if anything in between these two orthogonal planes is having like an aneurysm or wall motion abnormality? It will not be considered in the equation. So still, we have a lot of geometrical assumptions in the 2D assessment. Then 3D came into the market many years ago. It is not recent anymore. And everybody said that is the way to go. It is very accurate, and even it was advocated to be used in the chemotherapy patients. Why it is valid? Because they validated that against the MRI, and MRI is the gold standard for volume and ejection fraction, as we all know. And the 3D echo was the closest method to assess volume and ejection fraction compared to the MRI. And now we have reference values for 3D echo in many nations, but we are lacking now for the Egyptian population. Again, why? It is more accurate because it avoids the two main problems of the 2D. There is no apical foreshortening. Those who use the 3D echo assessment, they will know that they can open the apex fully till the end in the software. Second thing, there is no geometrical assumption. If the LV is aneurysmal, wall motion abnormality, it will go with the endocardium all around. There is no place for geometrical assumptions. Wherever it goes, it will go and trace the endocardium. If there is an aneurysm, wall motion abnormality, it will go and trace everything. So there is no wall motion abnormality. The problem, the drawback, because this is the title of the talk, indications and drawbacks, was the time consumption. Not everybody has the expertise to do 3D. Not everybody has the tool or the machine. And not everybody has the time to do 3D analysis. Everybody is busy. And say if I took a couple of minutes for each patient, that means in a busy lab, a lot of hours. And hours means money, right? Especially in the Western countries, time means really money, okay? Because the more patients you accommodate, the more fund you will raise and you will get, and then you can pay the doctors and so on. That's very valid in NHS in the UK or in the USA. Then the solution came with the fully automated softwares. Now, there is no issue about the time anymore. These kinds of softwares, one of them is like the heart model, one beat acquisition. Just you put the apical 4-chamber view, if you have the tool and if you have the machine, just 4-chamber view, and one click of a button, it will give you a full volume for the whole heart in one beat. And then one click for the analysis, it will give you the tracing for all the cardiac chambers. So it is now, we know it is accurate from before, and now it is fast and rapid and even quicker than the 2D. So just one click to acquire this volume, the 3D volume, and then one click for the analysis, you will get the tracing for all the 4 chambers in the heart. So it is really shorter time than the 2D assessment. The beauty of these kind of tools that in order to allow the software to detect this is anatomical intelligence, like a kind of artificial intelligence. So in order to develop this skill for the software, they fed the software with thousands and thousands of studies for different kinds of geometry. So you can do this for a normal shape of the LV. You can do this for the dilated LV, for the banana-shaped LV, for the sigmoid septum. As long as there are 4 chambers in the heart, it can work. I'm not speaking about the single ventricle DORV, that confusing stuff of the congenital heart disease. As long as the patient has 4 chambers in his heart, that's quite enough. This software can perfectly do its job and trace all the 4 chambers in the heart. Not only the left side, it is also tracing the right side and allow us to do automated RV assessment as well. The new concept of the left atrium volume and ejection fraction. This software can give you also automated assessment of the left atrial size and ejection fraction changes during the whole cardiac cycle. And that was validated with Professor Lang in Chicago and his team. And now the 3D RV assessment. So I've covered this. RV is very complicated. RV, if you look to the RV from the side, you will see the inlet part. Here is the tricuspid, the inlet part, and then the trabecular part, and then the outlet or the outflow part. If you look at the RV from the side. But if you look to the RV from above, you will see like a crescent hugging the LV. So it's a very complicated thing. And 2D, no way will be able to assess all these parameters or all these components in a perfect way. So we really need something 3D. In the old days, in the 2D echo, there was nothing called RV ejection fraction. We had nothing called 2D RV ejection fraction. We had only fractional area change or TAPC or anything. But nothing called RV ejection fraction except from the MRI before. But now with the 3D softwares, we have 3D RV ejection fraction. The problem of that tool, the conventional RV assessment tool, it needed 17 steps. 17 steps. You get the full volume and then 17 steps to teach the software where is the LV apex, where is the mitral valve, where is the RV apex, where is the tricuspid valve, where is the septum. So a lot of steps. But we were happy because we had nothing before to give us ejection fraction from the RV. So we're okay doing this. Now, because we have the heart model we have just talked about, this tool traces all the cardiac chambers automatically. So instead of the doctor teaching the software where are the landmarks to get the RV, now the heart model teaches the software in one click where are the landmarks. So now we have the 3D auto RV. So again, one click of a button, not 17 steps. The beauty about this software that does not give you only the 3D volumes and ejection fraction, gives you also the 2D parameters. The fraction area change, the TAPC, all of this fully automated. So it is now really saves a lot of time. As we said, it is not all about the ejection fraction. We have the speckle tracking as well. 2D speckle tracking is the widely used method now, but as you can see, we have 4, 2, and 3 chamber view. What about the other, like endocardial or the muscle parts in between these 3 planes? It is not measured. It is not considered. That's why 3D speckle tracking now is a promise. It traces the speckle within the 3D volume, so no way the speckle will go out of the plane. It will still trace the speckle all around the heart, and it gives us, apart from the volumes and the ejection fraction and the mass and the synchronous index, it gives you the GLS, the GCS, circumferential steering, the twist and torsion, all of that fully automated again with one click. Patients on chemotherapy, it was clearly stated from the recent guidelines and from the position papers that 3D echo-based ejection fraction is the recommended tool for assessment, followed by the nuclear, the MRI and biomarkers. And they stressed that if you have a modality that is reproducible, it gives you data not only about the LV, also the RV, about the hemodynamics, this tool is more preferred compared to the other things. And this state-of-the-art review about the multimodality imaging cardio-oncology stressed that echocardiography, especially the 3D imaging, and nicely they bought the picture of the heart model because it is very reproducible. Why reproducible? Because it's fully automated, no human interference, just one click. If you got like 50 doctors clicking the same click, you will get the same results. So fully reproducible. And they said quantitative assessment of the LV is essential with three-dimensional volumetric assessment being preferred owing to higher accuracy and reproducibility. And they recommended clearly that if the patient started his assessment with a certain modality like echo, he should do the follow-up with the same modality to be valid and to be reproducible. If you started with MRI, you should do the MRI again, and so on. And if you have a 3D echo, especially the fully automated one, that should be the way to go for follow-up with the same patient. Even in the UK, they were sending the patient for the same doctor to be done on the same machine. Okay? And that was clearly stated down here, that the first thing, the recommended thing, 3D ejection fraction, followed by CMR, followed by Simpson, and then the MOGA scan at the end. So with these parameters, we can help those patients. Automated ejection fraction calculation and automated speckle tracking to assess the parameters. Lastly, the atrial fibrillation. It was always problematic to assess LV ejection fraction and volumes because of the variability. These automated softwares, again, one beat acquisition, but it can quantify multiple beats, like 3 to 4 beats, and then take the average for you. Again, automated gives you the average ejection fraction and volume for the same patient. So in conclusion, 3D echo plays a very important role in patients with heart failure because it addresses the LV, RV, and speckle tracking echocardiography. Thank you so much. Heart model per se, that's a Philips production وموجود بس على الجهاز on card على الجهاز عشان هو معمول to speed up the workflow لأن هو وانت بتشتغل تران ثوراسيك one beat acquisition just one click على الزرار على الشاشه heart model acquisition وانت بادئ بفور تشامبر فيو بيعمل acquisition للفوليوم بعدين تجيب الفوليوم ده one click على التاتش سكرين بيعمل له اناليسيس وكل الريزلت دي بتتحط في الريبورت فهو موجود حاليا على فيليبس بس وفاليديتد بقى في الكيموثيرابي وفاليديتد في الفوليومتريك اسسمنت والايجكشن فراكشن اجينست ام ار اي.
مش اوبريتور ديبندنت، مش بيعتمد على الفيو جايبه كويس او لا، فور شورتند ولا لا.
لا الميزه فيه ان هو مش هيتاثر بالفور شورتنج لان هو بيقدر يديتكت اوتوماتيكالي ذا اندوكارديال بورد. انما طبعا ال 3 دي از رول لازم ابدا ب 2 دي ايمج كويس. يعني دايما السؤال اللي بيتسال هو المريض ده اعمل له 3 دي ولا ما اعملوش؟ ال 3 دي مش هو اللي هيجاوب على سؤال لو في بور ايكو ويندو. يعني لو مريض عنده بور ايكو ويندو كان زمان قبل ما الناس تبقى اوير بال 3 دي بيشتغل ازاي بيعمل ازاي يقولوا طب ما نبعته يعمل 3 دي. لا اكشوالي اتس جونا بي ورث، هتبقى اسوء لان ال 3 دي فريم ريت وريزوليوشن ليس ذان ذا 2 دي. انا عايز صوره كويسه قوي بال 2 دي عشان اجيب صوره، انا بقول كويسه قوي 2 دي عشان اجيب صوره كويسه بس مش قوي بال 3 دي. تمام؟ هو لازم كده. انما امتى 3 دي يفيد؟ لو انا شايف صوره حلوه بس مش عارف الديلينيشن بتاع الاناتومي. زي في التي اي انا بشوف برولابس بال 2 دي تي اي عادي، انما 3 دي بيفيدني بايه؟ البرولابس ده منين لفين؟ كام سكالوب؟ شايف ماس معينه في ال 2 دي شايفها، شايف بارافالفولار ليك بال 2 دي تي اي شايفها، بس البارافالفولار ليك ده واخد قد ايه بقى من الميترال فالف؟ شكله ايه؟ هل تريانجولار هل راوند؟ ال 3 دي جاوب في الحته دي، انما مش هو اللي هيجاوب لو في بور ايكون.
اي اسئله يا جماعه؟ حد له اي استفسار؟ شكرا دكتور هاني، كتر خيرك، شكرا جزيلا. دكتور طارق اتفضل.
السلام عليكم. الحقيقة أنا مش عارف أقول إيه بعد المحاضرات الهايلة دي. يعني أنا وسط الجوروز أوف إيميجينج مش عارف هروح فين يعني. أنا شرفني طبعا إن أقدم المحاضرة دي، وكان ليا شرف إن أنا أقدمها قصاد الدكتورة هالة في كارديو ايجيبت 2020. وعشان كده الدكتور حسام رشحني إن أنا أقولها تاني. أرجو إن أنا ما أبقاش ممل يعني. هو طبعا هو الابروتش بتاع اللانج الترا ساوند واحد من الميثودولوجيز اللي هي بتبقى مسد، والحقيقه يعني اتس ا فيري امبورتنت تول فور ذا كارديولوجيست. هحاول ان انا يعني ابروتش التوبيك ده. historical background سريع إنه since 1819 the French physician Laennec introduced the auscultation وشايفين بيعمل auscultation ازاي of the chest as part of the cardiac examination. In the 90s, lung ultrasound was first proposed with pioneering application in the critically ill patient, and in 2004, transthoracic echo was combined with lung ultrasound to detect pulmonary congestion in patients with heart failure. It took like 50 years of the transthoracic echo practice before shifting the transducer just a few centimeters from the cardiac acoustic window to examine the lungs. So the lung ultrasound requires training, proper transducer, technology, and the know-how, which is the technique. طبعا the identification of the B lines, which is the most pathognomonic and the easiest method to assess the lung, is actually a reproducible sign. It is considered like the kindergarten level in the echography, whereas, for example, the wall motion abnormalities is considered like the university level. But we as cardiologists are being taught the wall motion abnormalities and how to interpret it before just being taught how to assess the lungs by the lung ultrasound. So we use just the conventional transducer, a 3.5 to 5 megahertz transducer. So the cardiac probe is quite very effective. It has a small footprint to fit into the narrow intercostal space where we assess the lung tissue. It gives this image. The ribs, of course, will be obvious with these white arrows, and the lung tissue in between. Actually, the European Association of Cardiovascular Imaging has advocated the handheld devices to be available in the emergency departments to assess the lung in the emergency cases of acute heart failure. It requires no Doppler, no second harmonic imaging, no contrast, just a handheld device. And it can rule out, with a negative predictive value of up to 100%, it can rule out acute heart failure. What do we target? We search for extravascular lung water, pleural effusion, and more importantly, the pulmonary congestion, and other signs of interest like the pleural line, the sliding motion of the lung, the pleural space, and the interstitium of the lung. So this is the technique. The probe position is either a longitudinal scan, as we have mentioned, showing the ribs as the asterisks show, and the transverse scan. It shows the pleural line and the reverberations of it, which gives rise to what is called the A lines. So this is the normal lung scan. Well, actually, when it was first introduced, it was a very tedious procedure with 28 sites to be assessed in both lungs. Of course, nobody will do this, especially in a protocol of stress echo. If we incorporate lung ultrasound and stress echo, it's time consuming, and the time constraint will not allow us to do this. So they introduced further rapid and fast track techniques like the 6-zone method and the 8-zone methods. The 6-zone scanning protocol scans 3 spaces on either sides. So the first is in the second space in the mid-clavicular line, the second is the 4th space in the anterior axillary line, and the third is in the mid-axillary line in the 5th intercostal space. The nowadays adopted technique is what is called the blue points, the blue protocol. Blue stands for the bedside lung ultrasonography in the emergency. So we put the 2 hands of the physician or the operator. The first stands just beneath the clavicle and the other is adjacent to it. The first blue point is in the middle of the upper hand. The second blue point is in the middle of the lower hand. So those 4 points form like a trapezoid structure. And then a third point is just a lateral extension or continuation of the blue point. It's called the PLAPS, standing for posterolateral alveolo-pleural syndrome. And this is the point just above the diaphragm. So it's above the phrenic line. And this is because of the fact that in the supine position, usually air tends to go upwards in the most anterior segment, and any fluid will be in the dependent parts, so not to miss any fluids and pleural effusion. This can be done with this protocol. So simply, it's 4 areas on each side to be assessed. So in a simplified technique, we take like this figure. The yellow squares represent the parts where lung water could be assessed. It's in the third space between the mid-clavicular anterior axillary line and the other one between the anterior axillary and the mid-axillary line. Just scanning those spaces in the stress echo protocol would allow us to assess whether the patient has lung congestion or not. So how do we interpret the image? This is the normal default image where we see what is called the A lines. Air usually does not transmit the ultrasound waves. So what we actually see is the reflections of the pleural line, which are horizontal lines. These are called the A lines, sort of reverbation. So when we see these lines, this is the normal lung tissue as we can see. If we don't see this at all, then we probably could suspect that there is some sort of pneumothorax. This is another image showing the A lines and the ribs interposed between them. While in the case of the presence of water in the lung or lung congestion, usually what happens is the sound waves bounces between the wet alveoli instead, and creating what we call the pathognomonic sign, which is perpendicular line called the B lines. The B lines are like comet tail lines that are perpendicular to the pleural line, and they appear evanescently while we are moving the probe in the intercostal space, like this video that shows the B lines, I'm sorry, perpendicular to the pleural line. The sum of these B lines, and according to a score system, gives the degree to which the lung is congested. So the more the lines are, the more the lungs are wet and congested. Sometimes these lines become confluent, so they produce what is called a confluent B lines. And in this case, the quantification depends on how much is the percentage of these confluent B lines to the sector. So it's like if it's 50% of the sector, then this is like 5 B lines. If it's 80%, then it's like 8 B lines. Of course, the pericardial effusion, the pleural effusion is very important to be assessed as one of the signs of extravascular lung fluids. And it's very important to differentiate it from the pericardial effusion. And as we all know, the descending aorta in the parasternal long axis view gives us the delineation whether it is pleural effusion or if it's pericardial. If it's pericardial, then the descending aorta is spaced or distanced from the cardiac silhouette. So when we look to the pathophysiology of pulmonary congestion, we know that there is what is called the lung water cascade. So initially, the patient is equilibrated by the Starling mechanism in the phase which is called the asymptomatic hemodynamic congestion, when the left ventricular end diastolic pressure and the capillary wedge pressure is elevated. And then if we want to provoke this asymptomatic hemodynamic congestion, we do a stress test to provoke the development of the stress B lines in what is called asymptomatic pulmonary congestion. At rest, if these B lines appear, then this is another stage, and escalated up to the stage where the full clinical picture of acute decompensated heart failure is over. So the point is how to diagnose the patient early on along this cascade, not waiting for the clinical symptoms to appear. This is the picture of the stress echo. We can see that the B lines in cases of stress becomes exaggerated and provoked compared to the resting state. What is the clinical evidence behind that? Well, this is the stress echo study, which was published in 2020. This is an international echo study recruiting 10,000 patients in ischemic and non-ischemic heart disease. And this study was actually assessing the versatility of stress lung ultrasound among the different things that are being assessed. So among the wall motion abnormalities for assessing ischemia and viability, the coronary flow velocity reserve, the mitral insufficiency, the LV elastance assessed by the LV end systolic volume. Among those also comes the extravascular lung water, according to the standard protocols that we have mentioned, as one of the most important things. And we actually assess this after the peak stress, unlike the other parameters which are assessed during the peak stress. how to differentiate between wet versus dry B line? Well, the most important is the pleural line, which is usually thin in cases of wet pulmonary congestion, while it is thick in the presence of interstitial lung disease. The movement of the lungs, the response to diuretics, and the increase with the stress, all these can differentiate wet from dry B lines. The implementation of lung ultrasound in the emergency department for the diagnosis of acute decompensated heart failure. In this multi-center study, it was found that an early lung ultrasound implementation protocol increases the accuracy of detection of acute decompensated heart failure. And the net reclassification index was almost 20%. That is that 1 in every 5 patients could be reclassified as having not acute heart failure just by early implementation of this lung ultrasound protocol. This is the CATUS protocol, which involves cardiothoracic ultrasound integrated protocol. So we do not only search for the filling parameters, the LV filling by the EE prime. We do not just look to the inferior vena cava, but also we look to these B lines, which is a very important tool for the assessment of acute decompensated heart failure. In this study, actually, it was found that the survival benefit of lung ultrasound responders was better than those who are not responding, and the intensified treatment based on lung ultrasound was better than the standard of care treatment. And this made the European Society of Cardiology guidelines implement early on in the urgent phase to assess the lung by lung ultrasound before even the other tools like the chest X-ray and ultrasound and computed tomography, etc. Is it important in the acute anterior STEMI? Yes, it is important in order to anticipate that this patient may develop heart failure. Only 38% of patients having more than 18 B lines are heard by the attending physician to have pulmonary rails. So it shows that lung ultrasound is more sensitive than auscultation in evaluating pulmonary congestion. The pre-discharge B lines is important also, but we have seen that patients with a higher B lines pre-discharge have higher incidence of heart failure rehospitalization or mortality, and thus it is more sensitive, as we have mentioned, compared to chest X-ray. This is why they provoked the lung ultrasound as the sixth sense, the new sixth sense. So the conclusion for a cardiologist, lung ultrasound is an add-on to transthoracic echo, just as lung auscultation is a part of the cardiac physical examination. However, transthoracic echo and lung ultrasound remain divided by decades by an invisible but impenetrable cultural wall. Once the cultural barrier had fallen, the cardiologists learned quickly what intensivists had known for decades. Lung ultrasound outperforms the diagnostic accuracy of the chest X-ray with a low-cost, portable, real-time radiation-free method. A wet lung detected by ultrasound predicts impending acute heart failure and may trigger lung decongestion therapy early on, and the doctors of tomorrow may still listen with a stethoscope to their patient's lung, but they will certainly be seeing it with ultrasound. Thank you.